This is on August 27. On the MR, you can see that there's a little outpouching here. This was followed up with CTA. You can see the outpouching here between 25 and 26. It's approximately stable, maybe a little bit larger here. Patient has meningitis. And on 27, just one day later, you can now clearly see that it has enlarged. Patient had a bleed, has an enlarging aneurysm, so we thought this is a good indication for now going for DSA and treatment. And here we see the left vertebral artery injection, an AP and lateral, and what you can see here is that the pica is coming off, turning around. Here we have the tonsillar loop, and the distal pica is here. And on lateral, you can see the tonsillar loop here. There's the aneurysm. 3D, pica is coming down, and there's some narrowing here, and significant narrowing then prior to the further course of the pica there. So we have right now the aneurysm in the tonsillomedullary segment here. Focal narrowing here. And we were in between thinking maybe this is a dissection, but in the course of meningitis, maybe this is like a type of mycotic aneurysm, although it looked kind of more dissecting in nature. You can see very nicely that it's at the bottom of the tonsillar loop. And given the fact that the patient had like a bleed and this growing aneurysm that even looks bigger now, we thought about treatment. And because the distal pica here was so significantly narrowed, you can hardly see it, but it was still patent, I felt that our best treatment option would be what in this case? What would you do to treat this patient? First of all, would you treat at all? Would you leave it alone? Or would you treat? Who's in favor of treatment? Who's in favor of leaving this alone? Okay, so we decided also to go ahead with treatment. And for the treatment, I was thinking about, in this case here, concentrated glue embolization to go as far distal as possible. I was a bit afraid of using an SL10, so I actually used the Magic 1.2 with a hybrid wire. And you can see that we were within the vessel. We then gave a little bit of verapamil to slightly dilate the vessel in order to get then the glucan with a pretty high concentration into it, completely occluding the vessel. We didn't lose anything in the periphery. And what do you think happened next? Yes, stroke. There.
Brainstem?
There. In the brainstem. Brainstem is a large area.
Pons?
Sorry?
Pons?
Pons? Why pons? Because we are actually here, no? Exactly. Posterior lateral, dorsolateral medulla oblongata, and this is exactly where the patient had his infarct. There were no thromboembolic complications. Actually, during the procedure, you could see that everything else was nice and patent. But the patient did have, as you can see here, dorsolateral medulla oblongata infarct. Right here on the T2-weighted sequences. Her outcome was not the best, fluctuating GCS due to her meningitis. Recurrent hydrocephalus, she developed vasospasm, but essentially was discharged MRS3. And this is just to show you that in some cases, when you do apparent vessel sacrifice in these regions, you will have predictable infarcts. And therefore, when we are thinking about treatment, you really have to have a very good indication to treat these patients. If you see that it's regressing, and if you see that, for example, what Serentaro showed today, that some of these dissections go away, you may think sometimes also about more conservative strategy. In this case here, no question, the patient had a bleed, the patient had a growing aneurysm. I think every one of us would, even knowing about the outcome, go back in again to do the same thing. And I will just very briefly show one additional companion case here, because kind of time is running a little bit out, that demonstrates where we can go maybe a little bit more easy on our patients. So this is a patient who presented with an acute occlusion of the right vertebral artery. You can see missing flow right on the right, normal flow right on the left. Patient has pica territory infarct here without involvement of the dorsolateral medulla oblongata. You can see that the patient's vessels are not very healthy. There's in fact evidence for previous dissection here. There's some irregularity of the vertebral artery here. For a patient who was, I think, 52 years old, the vertebral arteries are way too elongated, so that suggests that the patient has an underlying Loeys-Dietz syndrome, which was subsequently also identified. You see that the vertebral artery here ends and is likely dissected, and so in this case, of course, the patient did not present with a subarachnoid hemorrhage, so we just followed the patient conservatively. And over time, you see that now the patient develops an aneurysm here, and these aneurysms continue to grow. But what is growing is actually the mural hematoma, and it's leading to compression of the brainstem. I actually wanted to treat the patient, but the patient said, no, he does feel pretty good, and he wanted us to kind of follow him up conservatively. And this is what you see over time. This is at the acute stage, growing, really growing, making me really nervous, wanting to treat. But then over time, next follow-up, and here, regressing completely and spontaneously dissolving. So this just shows you, and we'll talk more about dissections later, that sometimes these dissections can be extremely variable and can even regress over time. And a conservative approach may sometimes be the more safe way to go. Okay, these were the two cases I wanted to show. Any questions for those? Yes, please.